You're listening to the What's Happening podcast with Gary Watts.
Good morning. I'm here with Dr. James Byrne, the Department of Radiation Oncology, University of Iowa. You're also a doctor and a PhD, and is it biomedical engineering? Is that right?
Yes, sir.
I did say it. I didn't stumble, did I?
No. That was great.
So, hey, I just saw you last week in your lab, and I was fascinated by it, and I thought we'd come in today and talk about cancer. I understand that I was ranked second, which we don't want to be too proud of this, but second of the most cases per capita of cancer. Is that true?
That's right. Right. Increasing incidence of cancer.
Good grief. I don't know but we'll get into that. So before we do, kind of like to get back in your background, where you're from, where you went to school, what you participated sports, what you did as a kid. And then I know you're happily married. You have, what, 3 children?
3 children.
Right. And so we can get into your wife. She's in hematology, right? Internal med.
Mm-hmm.
And just give us a little bit on your background before we get rolling on cancer.
Sure, absolutely. So, Gary, first off, thank you so much for inviting me to be here.
It's my pleasure. It's my pleasure to have you here, by the way.
So James Byrne, I grew up down in South Texas, about as far south as you could possibly go, right on the Texas-Mexico border.
Galveston?
Laredo, I guess Mission, McAllen, and then moved up to Laredo when I was in 6th grade.
Okay.
Played baseball out there. I mean, my mom is from Ireland. My dad is from Wisconsin. They ended up down on the Texas-Mexico border really for my dad's job. And so it was a unique upbringing. I loved it. Like
What'd your dad do?
He actually was a general manager of manufacturing plants across the border. So these are called maquiladoras. So they make products down on the Mexican side and then ship everything up north in the U.S. And so he was initially in manufacturing and I mean, he trained as an accountant before and then went into more managerial positions and then ended up right on the Texas-Mexico border. But it was a unique, I loved it. It was a fantastic upbringing. I mean, we were so heavily influenced by Mexico. Everything we did had a different tilt to it. And so celebrations, Halloween, we had the day after Dia de los Muertos, and it was just a kind of a very unique, different upbringing. My wife, who's from Galesburg, Illinois, her folks are from small town Iowa.
Where's that small town? Putting you on the spot.
I know.
There's a lot of small towns in Iowa.
Sheridan.
Oh yeah, we talked about Hy-Vee and all that. Sheridan, yeah, southern Iowa, down south of Ottumwa.
And he was in and worked on the train yards, and his dad worked in the train yards as well. And so it took him out to Galesburg, where my wife grew up. And so, but when we talk about upbringings, her upbringing was completely different than my own. And so it's cool to see that and to hear about her experience.
We won't get into politics, but how was the border? Was there a border wall then? Was it
more
controlled?
It was no, there was no control. I mean, it was especially prior to 9/11. It was pretty easy to go across and then come back without any issues. And I mean, we used to on weekends we would go across to North Laredo and actually go get vanilla, or I mean, there were certain things that were a lot cheaper across the border, and that we would go see and go eat and then come back. And my dad driving it every day, it was just a part of his normal life, and so it was great. I loved it. I know things have changed a lot, and especially with in terms of drug violence and gangs and other things, that happened more when I was in college. So the mid 2000s, where they started to see really this influx in violence. And so it became a little less safe to be able to go across. And so people had to be more careful. But I still love the people there. I still have a number of great friends out there, and my family now lives in San Antonio. And so I have 3 siblings and an identical twin brother who's a maternal fetal medicine doctor. He takes care of high-risk pregnant women and does so in San Antonio. And so that's where we end up going back for holidays. But in terms of, we ended up, I ended up doing high school down in Laredo, and then making my way slowly up north to Austin, Texas for undergrad, and then over to UNC Chapel Hill for my MD PhD prior to going to Boston to the Harvard Combined Program for Radiation Oncology, and then did my postdoc work at MIT.
So when you were in Laredo in high school, did you want to be a doctor? Did you
I
want
had
to be
no
a
idea.
scientist?
I knew I wanted to do some science. So I loved science and math. That's what really drove me, and that's what got me excited. And so when I went to college, I ended up going into biomedical engineering, and I thought, well, what's the hardest thing I could possibly do? And that ended up in my frame of things, that ended up being it, and I just loved it.
At Texas, University of
Texas.
Texas.
Yes, sir. And then one of the huge and most important things that I think that I did during undergrad was getting involved in research. And we were somewhat forced as undergrads to get involved either in research or industry. And that was life-changing. I fell in love with research. I knew exactly that I wanted to create new things that could potentially help people one day. And that gave us the ability to do it. And so we were able to explore unique and innovative ideas. And then one of the things that also really came to light early on was translation and trying how we can get these things to patients. And so I thought that going and doing both medicine and my PhD really was a nice way of converging these two areas so that we can translate things to people faster and get discoveries that we make on the benchtop in the lab to patients. And so I'm excited that that's where we're going, and that's some of the things that we're interested in doing right now. But it wouldn't have been all what I'm doing right now wouldn't have been possible without doing that and what I did as an undergrad. And so it was super cool. I have to give all my hat off to the folks over at University of Texas, because they were really setting the foundation.
That got you started. And you ended up in North Carolina. Is that for your PhD in med school, or?
Yes, sir. So ended up doing, they have an 8-year, and this is common across most big academic medical centers. They have a combined program that's an 8-year program generally. And it's funded by the government, where they pay for your med school, they pay for your PhD, and you get a living stipend to be able to not come out with any debt. And so that was huge. And so I went through that 8-year training program, continued to love and really flourish in terms of the research, loving the research, and wanted to do clinical work. And so afterwards ended up going on to residency in radiation oncology.
In North Carolina?
Actually, that one up in Boston. So I did my, the way that the program is set up is that you have to do a year of generalized work. And so I did my year of internship over at UNC hospitals, and then went up to Boston for my 4-year program.
It was a 4-year program. Mm-hmm. So then you got out, then you came here? Or?
Then got out of residency, and my wife, and even early on, my wife wanted to come back to the Midwest. She had targeted that throughout the entire time that we've been together, and wanted to get back to really closer to home, closer to her friends, closer to her family. And so when we were applying for jobs, this is really the place that we had zoned in and targeted in on it. John Vawadi, who you know well, I had reached out to him when I was a very, very early resident. And I said, look, we want to come to Iowa if there's the chance to. What can I do to develop myself to be able to make it out here? And so we were fortunate to be able to come out here and set things up.
Isn't it funny? You're probably in Boston. You go, hey, I'm going to Iowa. They look at you and go, huh? Where's Iowa? Sometimes you get Idaho, you get Ohio. No. It's a 4-letter word, but it's Iowa.
That's right.
What do you do in Iowa? It's just corn, pigs, cattle, beans. That's it. That's all they think. Then when they get here, they love it.
Yeah, that was the one of the fortunate things is one of my mentors out in Boston is an Iowan, and so he went to Iowa State, ended up going and making his way out to Boston, but he loves Iowa, and so he was. Anytime anyone would say Iowa, it's a little atypical. He would be like, "No, you don't understand. This is a fantastic place with good people.
Yeah, especially for medicine and also to raise a family.
Yeah.
You know what I mean? I'm sure that can. So when did you start having children? And you got,
So we started having children when we were back in North Carolina, and then had our second in Boston, and then third actually out here.
and how old are the kids now?
8, 6, and 1.
So you're staying busy, right?
Well, it's crazy busy.
Are you sleeping yet?
well, fortunately, we are. Yeah, we after about 8 months, when our youngest was 8 months old, we started to sleep a little bit more. We didn't have to wake up or get those midnight awakenings.
I just saw somebody yesterday has a newborn. I'm like, he's getting 3 hours a night. I go, oh man, good luck. So having fun.
I think everyone goes through this where you don't realize how well you can function on such little sleep.
Right. Yeah. So now you're at Iowa. So let's start getting into research and what drives you. And let's go back to the cancer, second ranked.
Mm-hmm.
Tell me, and I understand that we're going to all 99 counties to try to figure out what's going on. What do you think's going on, or what's your thoughts?
I think that there's a lot of environmental factors that are playing into what we're seeing.
Water,
radon, pesticides. I think that there are a number of key things that are really driving those cancer rates and the incidence of cancer. And it's in general, and this is throughout really all of cancer, it's generally a combination of things that are driving factors for development or what happens in terms of having or developing cancer.
So you think nitrates, the water combination. I know radon's real high here.
Mm-hmm.
You know, every house we build, we have radon mitigation in it, or,
Right.
or be able to, if the test's high enough.
Mm-hmm.
So everybody knows that. But so it sounds like they're going to each part of the state. Sounds like Northwest Iowa is more prostate cancer.
Mm-hmm.
The center of the state's more breast cancer, lung cancer to the south. I don't know if I'm saying those right, but it sounds like they're identified. Different parts of the states have different types of cancer. So
yeah.
What's the relevance in knowing what's what? It's just a database, or trying to?
I think it's seeing if there's any preventable causes that we can go after. If we identify what any of those common themes are, if we can try and prevent, whether it be radon mitigators or whether it be figure out key factors that we can prevent the future development of cancer. It's hard to prevent what is happening now but I think this is really for the future and for our kids. It's hugely relevant. And right. So, but if we can identify those, we can prevent it.
So if you went to Chat GPT, not that I did,
mm-hmm.
and you type in, what is cancer? How would you describe it?
So the way I describe it to my kids, because my wife being a medical oncologist and myself as a radiation oncologist, we talk to them about cancer and we tell them that it's when you have parts of your body or cells in your body that start to grow out very weirdly or atypically, and can grow without the body stopping them from growing. And so it can sometimes grow to the point where you can see a big lump or have kind of a big growth, but it could also go other places. And when it goes other places, it is really, really hard to treat. And it's something that we are trying to figure out how to address these in general, but it's this atypical growth that can hurt a lot of people in different ways.
So the cells naturally die, and these cells don't.
Mm-hmm.
Is that right?
Yeah. Go ahead.
What triggers it? What triggers something to grow abnormally?
So it's generally the combination or the accumulation of mutations within really the building blocks or the fundamental aspects of the DNA within cancer cells, within cells in general. And so that allows them to grow abnormally or uncontrollably. And then they develop these unique properties of evading the immune system, evading and becoming what comes to mind is like a ninja at night where you can't see the ninja and they just continue on to persist. And so that happens with cancer too, really as a function of the uncontrolled growth because of DNA damage or mutations that happen.
What are the different kinds? I know that blood cancer.
Mm-hmm.
Can you go through the different kinds of cancers?
Oh yeah, there's there are so many. So we break it down in terms of the clinic, solid tumor versus more blood cancers, and we call those malignant hematologies. And so within that, in terms of the solid tumors and what most people think about in terms of cancer, like breast cancer, prostate cancer, there's a large number, and we break it down by especially areas of the body. And so when you go see an oncologist generally, and especially at a place like University of Iowa, there's subspecialists in those areas. And so I focus in clinical practice is really treating genitourinary, which prostate cancers, bladder cancers, kidney cancers, as well as a small volume of patients with GI cancers, and that's like prostate or pancreatic cancer, esophageal, rectal cancer, and a few others. But there's a large number of different cancers, and it really is depending on where the cancer cells were derived from before they started to potentially go other places.
There's no easy answer then, is there, with all the different kinds of cancers, where it came from, what's going on? Is it part of your DNA? Is it part of your, how you're raised? I don't know, what you've been exposed to.
Yeah, no,
there's so many factors, aren't there?
So many factors. And when someone asks me, well, how did I get this? It's hard to say exactly what it is, because there's so many things that go up that make up our day-to-day, make up like what we are exposed to. I mean, our vets, our Vietnam vets that were exposed to Agent Orange, that's something that we can point to and say, this is one of the factors that really contributes to your development of cancer. But for the general person that didn't go to Vietnam, it's hard to say exactly what it is.
There was something I read, I don't know what I was doing, something I saw, and it was about John Wayne. I don't know if you knew this. He's from Winterset, Iowa.
No, I didn't know that. That's cool.
So aren't you glad he came on? But and then he ended up playing football at USC, which is kind of interesting. But he was from Iowa as a kid. But anyway, he had a show. He did a movie, some Western in the early 50s. And they went back and researched that like 40 or 50% of those folks that did that movie had cancer. And apparently it was near a nuclear facility that was, I don't know what they do underground, and and they had Geiger counters around them that was going off. It's like they kept shooting the scenes. And I think John Wayne died of I could be wrong. I think lung cancer or something. But over half of them over time. So obviously radioactivity would not be good, right?
Absolutely.
But I found it fascinating that back then we didn't protect them. They were drinking the water. They were. So, but anyway, moving on, so many different kinds of cancers. I read on prostate cancer. I'm a prostate cancer survivor. So, I had, at Mayo Clinic, they did took the prostate out, went through that. And then Dr. Tracy did some post surgeries for me and here at Iowa. So a lot of it initially you go, well, why did I get cancer? How did I get cancer? I didn't realize all men have prostate cancer, some degree. Especially over 50, and it's just whether it grows or not or whatnot. So as a guy, you're gonna have to deal with it.
Yeah.
But obviously, when I decided to have surgery, I didn't want it outside the box, I call it. And then you get bone cancer, and you don't want bone cancer, right?
Not at all.
So I think once you're a cancer survivor and you talk about cancer, everybody that you know has dealt with something in their family or somebody they've known that's had cancer.
Yeah.
So when you talk about cancer, it's kind of a dirty word, but then again, you've had some kind of exposure to it. I remember when I was a real young kid, I remember going to the hospital and my uncle had, I think, lung cancer. And I was just a little kid, and I walked in the room and I looked up, and he's a big, strong, 200-pound guy, big farmer, and I think he weighed like 90-some pounds then just before he passed away. And I'm looking at him like, what? As a kid, you don't know what's wrong with him. And it was lung cancer. So, I think part of it, you talk about prostate cancer, talk about too much red meat, it's your diet, stay healthy, exercise. But, isn't it true as a physician, you tell everybody, right?
Yeah.
Reduce red meat, maybe a little bit, not, everything in moderation, right?
That's right.
And then stay in shape or walk or do something. And I noticed that during COVID in my office on Oakdale Boulevard. So guess what? I started seeing people walk. I started seeing people jog, and I started people on bikes. And I think, thank goodness that, they're doing something now, because it seemed like it motivated people to get moving. So talk about cancer maybe from a stand, and then I want to get into research.
Sure, absolutely.
But talk about the physicality of staying in shape, your diet. How important is that with what you see in cancer research?
Oh, hugely important. I mean,
Okay.
I just came back from a conference set up by the V Foundation for a grant that I have, and researchers, and this is really coming to the forefront and has been at the forefront recently, is really the effects of obesity on cancer and the development and aggressiveness of cancer. And so being active, exercising, staying in shape, everything in moderation are huge, important, really life principles that we need to follow that help really keep cancer in check and help mobilize our body to fight off any cancer cells that could be present. I mean, we have so many cells in our body that at times they can't, like even now we probably all have some degree of kind of atypical cells that will grow and then the body fights and kills them off. Exercising, eating well, sleeping, like those are critical things that can help restabilize the body to fight off anything that is atypical in the body. And so there's more research coming out regarding this, this being so important, really, because as we start to see the population become obese, it's a huge predictor for development of cancer.
Right.
And if we can avoid it just with exercise or with a better diet, that can help.
I think, during John Kennedy in the 60s, we all had PE, but PE was serious. I mean, you showed up, you had an hour, and it seemed like back when I was a kid, it seemed like the guys that are PE teachers were old World War II vets. So you didn't go out there and fiddle around. You ran, you had your tighty whities on, your little white shirts. And, and they pushed you, and you were doing pull-ups, sit-ups, all that stuff, running.
Yeah.
And it seems like we got away with that. And I think under RFK now, they're going to get back into it. We're trying to make us healthy again. I think that's so good because you don't ever get that push. It doesn't seem like in schools and where to eat right and to stay physical. I think that's a good thing.
It's such a simple principle, but it's important. I mean, and it's going to be helpful in so many aspects, not just in terms of cancer prevention or fighting off cancer, but then also mental health. I mean, there are so many great avenues and aspects to being physical and physical activity that we do need to get back to really some of those initial roots that were set up.
So you mentioned the V Foundation. You guys that are listening that don't know, that's Jimmy Volvano, coach at North Carolina State, right?
Yes, sir.
And if people don't remember, 83, 84, 85, somewhere?
82, 83.
There you go. You know, I've tested you. But what a dynamic guy. I just saw something the other night, and when he got up at the ESPN, could hardly walk, but he got up and he gave that speech, I'm not going to quit. I'm going to fight this. And his foundation is just, isn't it just $500 million, or I don't know what it is, for cancer research, still grows. They have golf tournaments. But if you want an inspiration for cancer and an inspiration for a person, look into YouTube, Jim Volvano, just a great dynamic speaker. And if you don't know much about him, what year was it they won the national championship?
I think it was 83.
Was it 83?
It was 83, yeah.
And well, back then I remember seeing it. They went up against Houston, and Houston had, I think, Akeem Olajuwon, and they had Clyde Drexler. I mean, they had truly the best talent, just all fantastic NBA players. And here comes North Carolina State, and not that they weren't good, but they were. But they took it to Houston, and they beat Houston. And that was kind of like David versus Goliath, kind of, and as good as Houston was. But they ended up beating him at the end, and I remember Jimmy running around, but it just set him up. Of course, then he got, a cancer diagnosis. I don't know what it was. Was it blood cancer or
I thought
what he had? But it just, anyway, he ended up, he could hardly walk. But what an inspiration to keep fighting, and what a great guy. And I'd encourage everybody to look up his foundation, contribute to it. And
in fact, the CEO of the V Foundation is an Iowa guy. So Shane Jacobson.
Really? Here we go again.
Went to Iowa State. So he has deep roots out here, and such an incredible foundation. They do so much for cancer research and are really pushing. And as we're seeing really changes within federal funding, I mean, this is an important thing within research. We need areas and teams to really step up. And so the V Foundation is stepping up to try and help support cancer researchers so we don't really get behind, so that we continue to stay at the forefront of innovation of cancer research and keep the United States really at the cutting edge, so that we are leading the entire world, leading those innovations. And so it's so important.
So at Iowa, tell me more about, I don't have this right, there's national cancer research facilities, and we're one of the top 5 to 10, or how do we rank? And I know we're re-upping for that for the next 20 years. And where do we rank? And tell us about the national register or whatever we're
Absolutely.
on.
So we, the University of Iowa is one of the a comprehensive cancer center, and is a designation by the National Cancer Institute as being one that really addresses all aspects of cancer. And they give extra support and federal funding to help support the University of Iowa to do so. We're the only one really in the state of Iowa. In the surrounding regions, there are others. You have WashU in St. Louis, University of Minnesota, I believe, University of Wisconsin. But in terms of really bolstering the state, this is one huge boon to the state in terms of how we are set up, and it helps to recruit talent. It helps to recruit me to the University of Iowa, just because we had really the foundation necessary to be able to do really excellent research and provide excellent clinical care. We're certainly in the top 40 for cancer center across the nation. Within the Midwest, we're one of the top cancer centers within the Midwest, and certainly compete with University of Wisconsin, WashU, University of Minnesota, Mayo Clinic, and a few others. And so we're within that realm. But having this NCI designation is really, really important. And so I know with Dr. Mark Burkhardt, our cancer center director, really helping to support and re-up and resubmit the application for the Comprehensive Cancer Center is really important.
It sounds like they're looking to potentially build a new facility with like 135,000 feet of just lab space.
That's right.
Seems like a lot of lab space, but that's great.
It's necessary. We are bursting at the seams right now, is to try and have enough space. Where I trained for my postdoc, we were crunched for space. I mean, it was an incredible lab, and like I could basically reach out and touch other researchers right next to me working side by side. And so it's nice to work in a space like that. But I think we need even more space, and having a new building really geared for cancer research is so critical.
I don't know where it's at, but it's supposed to be at West Lawn would come down. And
that's right. It's right across actually from where we met my lab currently. Okay. So it's there was a parking deck, and then the West Lawn building, kind of one of the older ones there.
So it just seems amazing, and 135,000 feet just sounds amazing. So let's get into some specifics of what you're working on. I know you had some things you talked about pop rocks for children, and all kinds of fun things. So tell us about your research. What's the latest and greatest, and what you're working on right now?
Absolutely. So I like to start off with telling a story about one of my patients. And one of my patients she was a middle-aged woman who came in with a large tumor involving, it was a soft tissue tumor called a sarcoma, involving her left arm and the nerve governing kind of movement of her left arm. She'd previously undergone really the standard treatments of radiation and surgery, and then it came back, and this was super aggressive. And so she had to make the decision on whether to go on for amputation of her arm and shoulder, or go for radiation again, which was going to kill off the nerve, causing her arm to be fully paralyzed. It was her situation and situations like this that really prompted us to consider unique and other alternatives that could be really helpful. And so we took inspiration from the most random of places, Starbucks or Java House, any coffee shop. Wow. And I'll get into that in a second or two. But one thing that we knew about her tumor especially was that it had really low oxygen levels. And that's a common theme among a lot of different types of cancer. And because—
How do you know that? When you say low oxygen, how do you?
It's that Hertz tumor type itself is known for having these low oxygen levels. And as tumors grow extremely rapidly, they generally outpace their blood supply. So they're not able to reoxygenate those areas. And they create these areas that they call them hypoxic, but they just have low oxygen, low perfusion of blood. And so as a result, it's those areas that are harder to treat. They found, and this is a decades old concept, that they found previously that if you improve the oxygen of those areas, you can improve how well that tumor responds to radiation, chemo, and then now immunotherapy. And so we ended up really taking that inspiration from Starbucks and use their whipping siphon. So if you look at any coffee shop, you'll find that they have a foamer or a whipping siphon that they use to create foams on the top of hot chocolates as well as frappuccinos. And so we ended up reverse engineering the system to be able to create oxygen foams and have made not just oxygen foams, but oxygen pop rocks and oxygen things like gummy bears that we can directly inject in a very site-specific way in tumors to reoxygenate those areas that have low oxygen levels and then treat them with the standard treatments. And found, especially within mouse models, that we can have a profound impact in slowing tumor growth, in keeping the animal alive for longer periods of time. And so we're fortunate to have additional funding to take this into patients. And so now we're starting a phase 1 clinical trial in really a sarcoma patient population, but one that we could also take into other cancer types where we know those tumors have really low oxygen levels.
How do you get the oxygen into the tumor?
So directly inject it.
And through a syringe or
through a syringe?
Right into it. Because I know the first thing you do when you get to the hospital, oxygen saturation on your finger.
Yep.
So that has nothing to do with
only just based on oxygen, but we could do something like that to tumors and actually measure the oxygen levels in tumors and using imaging more than kind of a probe. But yeah, we have different tools that we have at our disposal to try and evaluate that.
So you administer to children chemo through pop rocks?
Yeah, so that's a project that we have ongoing that we're excited about, is trying to actually help our pediatric patients by creating unique and different forms of drugs to make them and increase the compliance with them. I mean, having 3 kids, having especially my older 2, I mean, I saw the challenges of actually getting them to swallow something or take a medicine. And if it tastes terrible, they'll spit it right out or they won't take it. And so that is a huge issue. And if we can figure out ways to improve or to help our kids take medicines, I think it's only going to be game changing in terms of increasing the effect of that medicine, as well as help them to have a more enjoyable or more enjoyment out of it rather than actually suffering through by swallowing medicines that just taste horrible or cause them to throw up. And so we're creating some unique ones involving pop rocks. And we have systems that are actually from the Quad Cities that allow us to do that, PAR instruments over in the Quad Cities. So when I first started, we popped over to this company to be able to have them really custom make a system for us. And then I've been using that to make pop rocks or systems that contain gas like that.
What kind of innovation do you have for like radiation with prostate cancer?
So we have, just in terms of radiation, we've done this in terms of creating, so there are different ways to deliver radiation for prostate cancer. One is we use these low dose rate seeds that can be implanted and inserted into the prostate. And generally men that undergo what's called brachytherapy, they'll have 30 to 40 seeds put in their prostate, emitting radiation and delivering it. What they do is, in terms of administering these, they generally separate the seeds out so that they don't give too much radioactivity and really cause a lot of damage. And so, but what they separate them out with is a spacer. And this is basically an inert material that the body absorbs on its own. What we thought is, can we improve the effectiveness of brachytherapy by creating these spacer-like systems that deliver oxygen? And so we have innovations where we've demonstrated we can increase oxygenation, which is going to make radiation more effective locally within the prostate. We also have systems that we have taken drugs that we know don't work within prostate cancer and combine them with other agents. And this is other gas molecules. Funny enough, it's going to sound weird, but carbon monoxide actually has this very unique property at low concentrations that can synergize with other drugs that have failed in prostate cancer. We can improve how effective they are, and so we've done that. And that's specifically important within the metastatic setting where people will have cancer in other places like the bones. And we've shown a profound effect there, really bolstering that. And that was cool work that we did with folks at other institutions, including Penn and Rutgers. And so we try and pull experts wherever we can. If we don't have them here, we pull them to be able to use their expertise to help us. But that's some of our initial work in prostate cancer. We've done a number of other things too, but those are really what come to mind at the forefront.
I was going to ask you, how do you cooperate with other institutions? Because you got so much going on, and if you find something, how do they know about it? And how does that work between all the cancer people?
I think the really, really important thing is cancer research is going to become more and more important about team science, working as a team. And we have the technology, which is fantastic, to be able to collaborate in very unique ways. And so we can use Zoom or Microsoft Teams or others to be able to communicate quickly, easily, make sure we're doing the right procedures, I'm a huge believer in team science. I think that the future of where research is going to be involving teams. And so we work with folks from Harvard, MIT, Penn, Rutgers, UNC Wilmington. I actually just struck up another collaboration with someone I met at the conference from Penn. And so, but I think there are so many brilliant people out there, not just within Iowa, but people that we can really tap into to be able to make these innovations and create new science that can help people.
What any innovations in breast cancer?
Yeah, there's a lot. So, at the university as well as beyond, there's a lot of great work being done, and people are trying to figure out ways to reduce side effects of treatment altogether. And so, and I like to break it down into cancers that are just localized to that organ. So breast cancer, if someone finds it early, it's just in their breasts. And then there's also the area where it's gone other places, it's become metastatic. And there's a lot of unique innovations to try and in both settings. One of the big things because cancer treatment is getting better, we have to find out ways to reduce side effects, because you just don't want to leave patients with these side effects that are long lasting, that cause them and change their lives altogether for the rest of their life. So you don't want them to have these severe side effects for the rest of their life, because it could make life a lot more challenging and harder, sometimes miserable. And so, but we were trying to figure out ways to do that, avoid surgery or avoid radiation or avoid chemo, which is great. And then there are others in where we know it's gone places, is really mobilizing the body's own immune system to be able to act on it and get rid of it. And we've had some crazy innovations in the last over 10 years now, especially with immunotherapy, where we've seen these profound benefits in cancers or in settings where we knew we couldn't really help patients. So in metastatic melanoma, with skin cancer, where it's gone other places, we knew as oncologists that was going to be a death sentence, that we knew that those patients would not survive for very long. Now immunotherapy has changed the game altogether, especially within melanoma, where we are curing people that have metastatic disease. And so we're getting to places that we've never been before. And that's being pulled into breast cancer. And there's a lot of fantastic research being done on that, trying to identify populations that are going to respond, as well as figure out where we can improve and personalize treatment based upon the person.
I've heard, is it true that concentrated vitamin C is working in cancer?
That's right. So the University of Iowa is one of the big leads on this, where they use IV or an intravenous form of vitamin C, and they give it really high doses, much higher than what you can take with orally, so by a pill. And so they give it during the treatments, and they found that they could have profound impact on how effective radiation and chemo is against cancers like pancreatic cancer, lung cancer, and a number of others.
It's so let's talk about a little. You got the research thing going on, innovation, and fundraising, so that Iowa they get federal money.
Mhm.
But just like the Jimmy V Foundation, you're always looking for money. So, do you know what the budget is, or how much money they need, or is that just constant of trying to bring in researchers and fund things, and between the state and the feds and donors?
Constant,
Just
yeah,
constant.
constant. I think there's a constant need. I mean, as the landscape of cancer research is always evolving, and I mean, one of the big things is the university, the federal governments, the foundations really want to fund unique, innovative ideas that um, have an import or have a rational strategy that makes sense, but then also can make a huge impact on people. There is always going to be a need to fund this research, fund these new ideas to try and take things forward, and it's getting harder. It's getting harder right now in terms of the main funder of research really is the federal government. And I think a lot of researchers, especially cancer researchers, are facing really the potential cuts that are being made to the federal funding. We're seeing a proposed 40% budget cut to the NIH's budget, which would kill a lot of the innovation and work that we're doing as cancer researchers. And so we're in a uniquely challenging time to try and figure out ways to fund our research. But I think we have to be optimistic and hopeful. And so we continue to push forward and look at possible opportunities that can help us really drive and fund our research and drive innovation.
You think of all the places we spend money at the government. You think we could spend money on research for cancer?
Oh my goodness, yeah.
Waste and whatever we're spending money on.
I agree. I mean,
It's just
we have to as a country, the United States, we have to keep our stance as being really at the forefront of innovation.
Mhm.
There are so many brilliant people. I've met so many incredible researchers and incredible people that are doing the craziest work and taking inspiration from so many different areas, but are really at the cutting edge of helping people and creating science and new treatments that could potentially help people. And if we as a federal government don't fund that, we're going to lose our stance and we're going to lose that talent to other countries. And yeah, it's something that I'm passionate about because I mean, as an American, as someone that was born, raised here, I want to see us really continue that trend and really help our nation be at that cutting edge.
Any innovations in chemotherapy and a type of drugs and
Yeah, so one of the things that they're trying to do, and there's a couple different areas within chemotherapy specifically, is personalizing and trying to create personalized strategies that are going to help people. And so they're always identifying or looking into groups of people with the same cancer type that we know will respond well or won't respond well. And so figuring out new strategies for those two different groups. There's a lot of small molecule development still ongoing within pharma, figuring out ways to really target other areas of cancer that we just haven't been able to do before. And so they're looking at, especially within pancreatic cancer, the undruggable populations, or the figuring out drugs that work on different targets that they've never been able to do before. And so it's exciting. They're creating these unique chemotherapies that will be less toxic and more effective. And so there's always innovation there and I'm excited. Even being at these conferences, I'm able to see and witness what people have done and created and thought about in a very different way. And so it's I can't wait for those to be evaluated and tested within people, because I think that's I think there's so much great work that is really on the horizon in terms of chemotherapies.
So give us your thoughts if you snapped your fingers and it's 10 years from now. Give me the innovation. What's happening? Tell us about cancer 10 years from now.
Goodness. So I think
Is it cured?
I think they're going to be, I don't think cured quite yet, but I think um, we are going to be treating especially patients with metastatic cancer and getting them to live longer and potentially cured than we're doing right now. I think that there are going to be new drugs that are going to help patients and mobilize even the immune system to fight off cancer. Um, I mean, it's going to be incredible. Now, the other aspect is making sure that we don't cause too much toxicity and side effects that leave them with having severe nerve pain or nerve damage or not being able to walk. And so, I think we're going to get there.
What do you think of? I see stuff come across. I look at it. Genetic testing will tell you if you're going to have a heart attack, cancer, whatever. Then also a blood test that detects whether you have cancer or not. What do you think of those things?
I love them. So I think those are fantastic.
Okay.
In terms of early diagnosis. I think, especially, and that is still, I would say, early days in terms of that work. But right now, in some cancers, we are using those blood tests to look at circulating tumor DNA to see if someone still has tumor or cancer cells present in their body. I think we're going to see that in all cancers or in most cancers at some point, where we're going to be able to detect really at an early stage if the cancer has come back and then figure out a way to intervene early. I think it's really at that window, at that early intervention window, where we can bring patients back to cure. And I think that's going to be even more important in terms of early detection, that we are going to be able to make a profound impact. And that's going to change the statistics. So that's going to change really helping more patients become cured of their cancer.
I think that's a good thing. It's like with prostate cancer, get your blood PSA test. I'm sure breast cancers get the imaging. Get a, what do they call it?
Yeah, mammograms.
Mammograms, have that done. Colonoscopies. There's preventive things that you can do.
Yeah.
Just do them.
Yeah.
And then that helps, get early detection. I'm sure there's a lot of this. And I think a lot of people, they don't want to go to a doctor. They don't want to go to the hospital, but there's things that you got to be doing.
Yeah.
The blood test, I don't think it was that expensive. I had one a couple of years ago. It wasn't that bad. Hopefully we can get it so everybody can have one.
Yeah.
And I just think you're right. I think, so to kind of sum it up, you got tons of research going on. If somebody's a young person in college listening to this and they want to get to Dr. Byrne and they're fascinated by research, what should they be doing in school, and what should they be majored in, and what?
I mean, so I think, and this is, as we go down the route of team science, I think having just a diverse set of interests can be helpful. So if someone, my team is made up of, and you had met a couple members of the team. We have marine biologists. We have people that are biochemists, biomedical engineers, and others. And so I think if someone has an interest, they can learn most of what they need to know and learn on the job. And so they can pick it up. And as long as they are eager, enthusiastic, have a good attitude, are resilient, hardworking, those are characteristics that are key in terms of research. And so I would tell them to reach out to people. If they don't hear from researchers or want to get involved in research, don't hear from researchers, just continue to reach out to other people or reach out to that person. They'll respond eventually. And if they don't have space, then that's fine. But just find what you're interested in, and don't hesitate to reach out and try and pursue.
And with the new facilities, you're going to need a lot of researchers.
Oh, yeah. Absolutely.
You're going to be hiring a bunch, I'm sure, doctors and researchers and whatever, right?
That's true. That's right.
Tons of people. Well, to finish today, I usually get into three things that more of a personal venue. So, I talk about the 3 H's. Who's your hero? What's your highlight? And what was a hardship in your life so far? So if you can start however, end however, I don't care, but think about those three things.
So hero, there are a couple of heroes, and I think from and some of them come from different aspects of life. One of my heroes is I have two major ones are researchers, people that I've worked with, physician scientists that have really set the stage and path for how to balance not just the research and the clinical work, but also family. Because you could be all in on one thing and then be imbalanced in terms of such a critical aspect of your life, which is family. And so I've had the good fortune of working with some incredible people and people that have really shown me how to balance the two so that I could still be present and there for my family, be at baseball games, be at really everything that is important to them and then also important to me when I was growing up. And so I think having those and those examples. And so the two people that are hugely critical to me are Gio Traverso, who was one of my mentors at MIT before I came out to the University of Iowa, and then a guy by the name of Joe DeSimone. He was my PhD advisor. And I look up to them. I still look up to them. I still see them as mentors and as heroes and someone that really set the example for me of how I should do this and how I can do this.
So they taught you the how to maintain your professionalism, your research, and your family.
That's right.
That's pretty cool to know because, I mean, a lot of people just say they just taught you research and focused on research and not the family. Mm-hmm. But they did the whole thing. That's kind of neat.
I mean, it's and so someone once told me that and this was a physician once said that the hospital is only going to love you so much. Like your family, like when you're retired, and it's your family that's going to love you and continue to stay with you. And you want to build and support those relationships, and those are critically important.
Good.
And so then the next one,
highlight or hardship.
So I'll go with hardship and then go on to highlight to kind of leave the listeners with the top. So hardship, I think every father, every mother can understand this is, I think one of the biggest hardships was, and going back to family, is figuring out the balance. When I was a father for the first time with our oldest kid. He had an accident, and where we had he was sitting within the baby seat. The baby seat tumbled downstairs. As a father, seeing that happen to your child, there was nothing harder than that. I mean, that hits. It hits deep because you never want to see your child suffer. You never want to see kind of your loved one really go through something that could potentially really impact their life to the point of like leaving them with huge issues. And so, but I think it's as a father, first-time father, learning about taking care of your kids, learning to deal with the uncertainty, the hardships of the being up all night with a kid. I think it's I'm fortunate that I haven't had severe hardships that have otherwise tested me in different ways. But I think as a first-time father, that hit home, and that was something that I've certainly grown from, but also one that I think still hits me to my core in terms of how to be and constantly working at being a good father so that I can be there to support them even in the unknown.
Is everything okay today?
Oh yeah, he's great. Yeah, he's a normal kid, normal 8-year-old. It's just one of those things that happened that really shook me to my core that I was never expecting.
One of the things I tell people is, when you see childbirth and your wife has a baby, it's a miracle.
Yeah.
It's truly a miracle. So the attachment to children is definitely there as a father.
Yeah.
That's a good one. So what about a highlight?
So I think probably the biggest highlights are also not for highlights of what I've been able to accomplish, but the people surrounding me. And so I think the biggest highlights really are seeing my wife happy and succeed in what she's doing. She's a medical oncologist, is a fantastic physician. She's a people person. Seeing her succeed in terms of the work that she does really brings me a lot of joy. And then also seeing my kids succeed at what they do. Our oldest, going back to him, he had his first hit in a baseball game and t-ball game this past weekend, and just seeing that just brings so much joy. He was so happy, and to see that, I think those are huge highlights that I are far exceed anything that I'm able to achieve within the work that I do. And so I think I'm proudest of most of those.
That's great they have T-ball now. Back when I was a kid, they didn't. You're throwing at each other, hitting each other. I can just set it there. I think I can hit it if it's right there on the tee. So,
yeah.
Well, Dr. Byrne, this has been fantastic. We sure appreciate having people like yourself here at the University of Iowa doing research. Obviously, being a cancer survivor, it's kind of near and dear to my heart and what you guys do. And I just hope and pray that every day that we're getting better and better solutions for folks that come in that are sick. And it just sounds like we need more folks like you. So I appreciate your time and effort and all the things that you do over there.
Cool. No, I appreciate you inviting me to be on. This is fantastic. And I couldn't be happier. This is your 69th podcast.
And I'm 69. So how about that? So good to see you. Thank you so much.
Absolutely.